So this InstaLecture would be on Wilson disease, and Wilson disease is a defect of copper transport. And there are two key diseases in pathology are there which are related to the defect in the copper transport. One is known as Menkes disease, MENKES, Menkes disease. This defect occurs due to malabsorption. In a way, it's a malabsorption of copper from the intestine into our body. And Menkes disease is a fatal neurodegenerative disease which occurs due to ATP7A, A for apple gene mutation. And it leads to lack of copper in our body, Menkes disease. On the contrary, the Wilson disease, which is the topic of discussion today, is a state of copper overload. Like hereditary hemochromatosis is a state of iron overload, similarly, this is a state of copper overload. And this occurs due to mutation of ATP7B gene before banana. Menkes disease was for mutation of the ATP7A gene. Please keep this in mind. Now, ATP7B, this is the crux of understanding Wilson disease, plays two crucial roles in the hepatocytes. ATP7B firstly helps the copper which is there inside the liver cell hepatocytes to be excreted via bile. So it helps in their biliary excretion. And by the way, the excess amount of copper mostly get excreted by bile in our body, 80 to 90%. So that is the main way. So when ATP7B gets mutated, there is no way that copper can be excreted out via bile from the hepatocyte. And ATP7B plays another role, that ATP7B helps copper to get incorporated into the apoceruloplasmin to make ceruloplasmin. And that ceruloplasmin get excreted in the blood. So that's why you get low ceruloplasmin in the blood of the patient of Wilson disease, because due to the defect of the ATP7B. And that ceruloplasmin, which is not bound with the copper, that may be released into the blood, but the problem is that is highly unstable, that don't stay for long. That's why overall in Wilson disease patient, as there is a defect in the ATP7B which is not allowing the copper to be incorporated into the ceruloplasmin, the total level of ceruloplasmin would be low, and which is a diagnostically useful finding. Before I discuss Wilson disease about further, you need to understand few basic concepts about the copper metabolism. Copper is an essential nutrient in our body which is required in a minimal amount, I'd say. Roughly 0.75 milligram per day is required. And we usually take it through our foods, various foods like nuts, legumes, 1 to 2 milligram. So the rest amount is excess amount of copper which needs to be excreted from our body, and that excretion mostly occurs via bile, 80 to 90%, and minimal amount occurs via kidney, 5 to 10% roughly. So when we eat the food, copper containing food, it gets absorbed mostly in the proximal intestine, mostly in the duodenum, like iron, and it then from there it gets bound with the albumin and then comes to the hepatocyte, and from the hepatocyte it could be released via apoceruloplasmin into the blood, and excretion would be occur via the bile. And both the cases ATP7B is the key molecule, and this ATP7B gets mutated in Wilson disease. And Wilson disease, by the way, is an autosomal recessive disorder. It's a genetic disorder which occurs due to mutation of the ATP7B gene, which I also mentioned earlier. So Wilson disease, you are getting a state where whatever copper we are eating actually through our various foods are getting absorbed into our small intestine, that is coming to our liver cells. And poor liver cells, they have no way to excrete them via bile, nor they can release into the blood via the ceruloplasmin. Both the pathways are blocked basically because there is a defect in the ATP7B. So net result is there will be more and more amount of copper would be accumulated inside the hepatocytes, the liver cell. And you know that the too much amount of when there's a copper is there actually, that would elicit I would say that free radical mediated damage. It would become toxic actually. And as such, free ions, they are not allowed to stay or roam freely inside our body. That's why you require molecules like ceruloplasmin, because free ions, if they are there, they are like some kind of mischievous kids, young kid, which can cause damage to the surrounding. So that's why we keep nannies or their parents when mischievous kids come to home or go outside, actually, because otherwise if they stay alone, they would cause a lot of damage, ruckus to the surroundings. That's why free ions, they are not allowed to roam freely. They're always bound with some carrier molecule, like in case of copper it is ceruloplasmin. So because they act like kind of nanny or bodyguard too, they remain attached with them, because if they remain freely they would cause Fenton reaction, which is a free radical mediated damage to the surrounding tissue. So anyway, coming back to the key point, that these hepatocytes, now they have no way to release the copper which has come from the GIT after getting absorbed. Neither they can release through via ceruloplasmin, nor they can actually excrete via the bile. So they are remaining there. The cell, they are becoming toxic effect on the cell, and at one point of time, all the copper which are there get spilled into the blood, and they get into the extrahepatic tissues. If they go into the eye, they basically get deposited in the descipient membrane of the cornea and causes a characteristic KF ring, Kayser-Fleischer ring, which is diagnostically useful. In the eye, even they can be deposited over the lens, and they can cause sunflower cataract. But sunflower cataract does not cause any visual defect problem as such. And more importantly, if they go to the brain, particularly in the basal ganglia, they get deposited, and they can cause this neuropsychiatric manifestation. And neurological manifestation, typically they present like quite like Parkinson like feature. There could be some movement related disorder, there could be tremor, there could be some rigidity, Parkinson like rigidity, there could be micrographia, speech difficulties could be there, and up to 20% cases there could be psychiatric manifestation also. There could be depression, there could be some compulsive behavior, phobias could be there. And other organs, mostly they can present with some arthritis, joint problem, they can cause hypoparathyroidism. In the kidney, they can cause Fanconi syndrome, which is a proximal tubular dysfunction. Don't confuse it with Fanconi's anemia, which is an inherited form of aplastic anemia. They cause Fanconi syndrome in the kidney. This is a characteristic manifestation. In the blood, they can present with hemolytic anemia. They can cause some damage, copper, to the RBC membrane, and they can cause this hemolytic anemia, Coombs negative hemolytic anemia. Diagnostic part, they usually, as I mentioned earlier, explained earlier, serum ceruloplasmin level would be low, because ceruloplasmin, the copper is not getting incorporated into the ceruloplasmin, and they're highly unstable, and they're not getting released the bound form actually. So ceruloplasmin level would be low because there's a defect in the ADP7B. Urinary copper excretion would be high. You can understand the logic, because biliary excretion is blocked, so whatever excess amount of copper is there now in the blood, actually they would be eventually excreted by kidney, so obviously the urinary excretion would be quite high. And another characteristic test we usually do, that per gram dry weight of liver biopsy, we can measure, quantify the amount of copper is there. And characteristically, typically the cutoff limit is more than 250 microgram of copper is there in this. And and the liver biopsy, the findings are quite non-specific. There could be acute hepatitis, there could be chronic hepatitis, there could be presence of cirrhosis some cases. In some cases, rarely, they could have progressed to the development of hepatocellular carcinoma also. Even in age 12 years of age, it could be seen. In the neurology, neuropathology, you can see a characteristic presence of Opalsky cell, which could be seen in the basal ganglia, particularly in the globus pallidus. So these are the key diagnostic findings which should be seen in this. I made a detailed discussion on the Wilson disease, but it can be uploaded here. I put it on my YouTube channel for this. Thank you very much.